Good afternoon, class. This is going to be Chapter 9, Principles of Airway Management and Ventilation. This chapter is actually going to have three different lectures. It's going to be split into parts A, B, and C. Alright, the objectives for this chapter are to review the anatomy and physiology of the respiratory system. Look back on Chapter 4 if you need to. We're going to define the following terms: abdominal thrusts, accessory muscles, agonal respirations, apnea, bag valve mask, biological death, cardiac arrest, chest thrust, clinical death, cyanosis, diaphragm, dyspnea, epiglottis, exhalation, gag reflex, gastric distension, head tilt, chin lift maneuver, hypoxia, inhalation, inspiration, jaw thrust maneuver, laryngectomy, larynx, nasopharyngeal airway or NPA, oropharyngeal airway or OPA, patent airway, not to be confused with patient airway, pharynx, pocket face mask, positive pressure ventilation, pulmonary resuscitation, rescue breathing, respiration, respiratory arrest, respiratory compromise, respiratory distress, stoma, trachea, tidal volume, ventilation. Alright, let's continue on with some more objectives. We're going to state the oxygen concentration of room air. Room air, again, is going to be what you and I are breathing right now. Describe the common causes of respiratory compromise. Differentiate between clinical and biological death. Describe the signs of a patent or open airway. Describe the signs and symptoms of adequate and inadequate breathing. Explain the appropriate steps for rescue breathing with a barrier device. Describe common causes of airway obstruction. Differentiate between anatomical and mechanical airway obstruction. Describe the signs and symptoms of a partial and complete airway obstruction. Describe the care for a patient with a partial and complete airway obstruction. That's going to include adult, child, and infant. Describe the management of a patient's airway when there is a suspected spinal injury. Explain the indications and contraindications for insertion of an oropharyngeal airway. Explain the indications and contraindications for the insertion of a nasopharyngeal airway. Explain the benefits, indications, and contraindications of positive pressure ventilation. Describe the signs of adequate versus inadequate ventilations. Explain the indications for oral and/or nasal suctioning. Differentiate between manual, electric, and oxygen-powered suction devices. Differentiate the airway management of pediatric, adult, and geriatric patients. Demonstrate the proper use of the head tilt chin lift maneuver. Demonstrate the proper use of the jaw thrust maneuver with and without a pocket mask. Demonstrate the proper use of oropharyngeal airway or OPA. Demonstrate the proper use of a nasopharyngeal airway or NPA. Demonstrate the proper technique for oral suctioning using both battery-powered and hand-powered suction devices. Demonstrate the proper technique for nasal suctioning using both a battery-powered and hand-operated suction device. Demonstrate the proper use of bag valve mask, adult, child, and infant. Demonstrate the proper technique for providing positive pressure ventilation for a patient with inadequate respirations. That includes the adult, child, and infant. Demonstrate the proper technique for caring for a foreign body airway obstruction to include adult, child, and infant. Value the priority of airway management in the overall assessment and care of the patient. Explain the rationale for using a barrier device when ventilating a patient. Alright guys, that's going to conclude the objectives for this chapter. As you can see, it's going to be a lot. Just a lot of information here. This is some information you're also going to have to spend a fair amount of time in your book, because to most of us this is going to be new. So just put in some effort, bear with us, we'll make it through it together, okay? Alright, breathing. We'll get started with that. Alright, respiration is the act of breathing. Exchange of oxygen and carbon dioxide takes place in the lungs. Remember, that only takes place in the alveoli. Acid-base balance and pH. Body uses oxygen to produce energy. Respiratory distress is defined by an increased work of breathing. Respiratory compromise is defined by inadequate breathing. Causes of respiratory compromise can be asthma, bronchitis, a heart attack or myocardial infarction, severe allergic reactions, exposure to toxic substances, inhalation of superheated air. That's particularly important for you guys that work with the fire department. That's something you'll see pretty common. Alright, this is a respiratory anatomy animation. Unfortunately, the animation will not come through on the PowerPoint presentation and when I upload it to YouTube, so I'm not going to attempt it. I can try to find you a different animation and send you a link to it. Alright, hypoxia. Insufficient level of oxygen in the blood and other tissues. Respiratory arrest. Absence of breathing. And apnea. So absence of breathing is apnea, just for the record. Alright, cardiac arrest is going to be absence of a heartbeat. Clinical death, the moment the heartbeat and respiration stop. Biological death, too many brain cells die and the death is then irreversible. Can't be overcome by CPR or any advanced procedures. Alright, without oxygen, brain cells begin to die within about 4 to 6 minutes. Irreversible death may occur in as little as 10 minutes. That just means that CPR, especially early compressions, are absolutely critical, guys. It can extend the clinical death period and delay the biological death period if early CPR is initiated. How we breathe. It's automatic, guys. Lungs are elastic and they're expandable as well. The diaphragm is the primary breathing muscle. We talked about that in the last chapter. Inhalation, exhalation, and Boyle's law. The diaphragm contracts and moves downward on inspiration, and it relaxes and moves up on exhalation. If you look at the image on the left, the arrows are pointing down. That means the diaphragm is contracting and it's making the chest cavity larger, which we talked about earlier, creates a negative pressure. In the image on the right, the diaphragm is relaxing, is decreasing the size of the chest cavity, and we're breathing out. Now, what is the role of the brain and the central nervous system in the process of breathing? What are some complications that can result when treating ill and injured patient who has an underlying respiratory condition such as asthma? All right, first question, what is the role of the brain and central nervous system in the process of breathing? All right, so your brain and central nervous system control all of your breathing activities. We talked about it earlier. Your medulla oblongata is primarily responsible for controlling your breathing. Second question, what are some of the complications that can result when treating an ill or injured patient who has an underlying condition such as asthma? Just keep in mind that asthma is considered an air trapping issue, and you can have trouble actually ventilating the patient. You can have trouble getting air in and out of their respiratory system. All right, respiratory system anatomy. The major structures of the respiratory system as far as the upper airway goes are your nose, your mouth, your throat, your epiglottis, and your larynx. Lower airway is the trachea, the bronchial tree, the lungs, and the alveoli. This image shows the major components of the respiratory system. This is also in your book. You'd be better served to look at it in there. All right, respiratory system anatomy continued. Respiratory cycle. The diaphragm contracts, increases the pressure in the chest cavity. Air flows through the upper airway structures and it continues through the lower structures of the airway. Oxygen and carbon dioxide exchange takes place in the alveoli. Oxygen travels through the walls of the alveoli into the blood, then it gets delivered to the cells. Carbon dioxide travels from the blood through the alveoli walls, where it's eliminated through exhalation. Patent airway. Open and clear airway. That's all that means. An obstruction closes the airway. It can be your own tongue. It could be a foreign body or object, or just severe swelling of the tissues. You respond to the home of a 62-year-old male complaining of shortness of breath. He cannot speak in complete sentences, so you can tell his breathing is not adequate. Considering the respiratory cycle, what is happening inside of his body? All right, so let's repeat that question. You respond to the home of a 62-year-old male complaining of shortness of breath. He cannot speak in complete sentences, so you can tell his breathing is not adequate. Considering the respiratory cycle, what do you think is happening inside of his body? Okay, so if he's not able to breathe effectively, he's got carbon dioxide building up in his tissues and it's not able to offload into the alveoli and be eliminated from his body. He's also probably becoming pretty hypoxic. He's not able to get air in and out to have adequate gas exchange. So he's moving through the cycle and probably becoming hypoxic and hypercarbic. All right, signs of normal breathing. All right, signs of normal breathing include rise and fall of the chest, also adequate tidal volume. So when they're saying tidal volume, while you're looking for the rise and fall of the chest, you just want to make sure it's adequate chest rise. You're going to listen for air entering and leaving the nose and mouth. You can observe its skin color and observe the level of responsiveness. Feel for air moving into and out of the nose and the mouth in unresponsive patients. All right, this is a video, again, that's unfortunately not going to come through for us. I'll try to send you a link of a video similar to this, okay?
Following your initial patient assessment and control of any immediate life threats, you should obtain a baseline set of vital signs, which include pulse, respirations, skin color, temperature and condition, pupil size and reactivity, and blood pressure. The baseline set of vitals gives you a beginning place from which to make treatment decisions. As you retake vital signs, you will compare the readings to your previous findings. This is called serial vital signs. Serial vital sign assessment allows you to note trends in the patient's condition, such as a declining blood pressure or increasing respiratory rate. The act of breathing is called respiration. For the determination of vital signs, you are concerned with 4 factors: rate, depth, rhythm or pattern, and quality. The respiratory rate is the number of breaths a patient takes in 1 minute. The rate of respiration is classified as normal, rapid, or slow. The normal respiratory rate for an adult at rest is between 12 and 20 breaths per minute. When the depth of respiration is normal, the chest wall expands easily. In deep respirations, the rib cage expands fully and the diaphragm descends to create maximum capacity. Shallow respirations show very little movement of the chest wall and may be hard to count. Often, shallow respirations will need assistance with a bag valve mask. The normal rhythm to respirations is that inhalation takes only half as long as exhalation. Any pattern other than this can indicate serious problems such as a traumatic brain injury, hyperglycemia, or metabolic emergency. The quality of a patient's breathing should be easy and effortless, referred to as apnea. Any difficulty breathing which requires extra effort on behalf of the patient is called dyspnea and will need to be addressed with high-flow oxygen, assisted ventilations, or medication. Now let's examine the steps in measuring respiration. Look for the presence of breathing by watching for chest rise and fall. If you have just finished measuring heart rate, continue holding the wrist so that the patient is unaware you have moved on to assessment of respiration. Before you begin counting, observe the patient's position. Most patients in respiratory distress prefer to be seated upright or standing. Hunching forward is called tripod positioning and indicates severe respiratory distress. Note any abnormal noises during breathing. A high-pitched noise like stridor can indicate upper airway obstruction. Whistling or wheezing sounds may indicate lower airway obstruction. Bubbling, wet, or crackling sounds known as rales can indicate fluid in the airway. Watch to see how hard the patient works to breathe. Signs of labored breathing include use of accessory muscles, nasal flaring, or retractions above the collarbones or between the ribs. Note any abnormal respiratory patterns. Respirations that are very fast, very deep, or interrupted with periods of apnea can be signs of serious medical conditions. Determine the respiratory rate by counting the number of times the patient breathes in 1 minute. One breath includes both an inhalation and exhalation. It may be more convenient to count the number of respirations over a shorter time period, such as 30 seconds, and then multiply by 2 for the number of respirations in 1 minute. Avoid telling the patient that you are counting his or her respirations. Patients will sometimes alter their respiratory rate or pattern when they know that you are watching. At times it may be difficult to count a respiratory rate due to patient movement or talking. Respiratory assessment is important.
Signs of abnormal breathing: increased work of breathing, absent or shallow rise and fall of the chest, little or no air heard or felt at the nose or the mouth, noisy breathing or gaspy sounds. Breathing that is regular, too fast or too slow, breathing that is too deep or labored, use of accessory muscles in the chest, abdomen, and around the neck, nostrils that flare when breathing, skin that is pale or cyanotic. Cyanotic is what you would refer to if somebody has blue coloration around the lips, fingers. Sitting or leaning forward in a tripod position. Agonal respirations. Agonal respirations are slow, sporadic gasps of air from an unresponsive patient. Alright, what causes cyanosis? So cyanosis is caused by low blood oxygen levels. Happens when your red blood cells or hemoglobin are desaturated. It generally will cause a bluish tint in your lips and fingertips. Now, why is cyanosis considered a late sign? It's considered a late sign because it takes you a while to get there. You're not going to initially present with blue lips and blue fingers when you first start having issues breathing. It takes a while to get there. All right, so you respond to find a unresponsive 23-year-old male with a history of narcotics abuse. He's making snoring like breathing sounds with periods of apnea. What are these respirations called? All right, let me read the question to you again. You find a unresponsive 23-year-old male with a history of narcotic abuse. He is makes snoring like breathing sounds with periods of apnea. What are these respirations called? So these are agonal respirations, guys. This happens when an unresponsive patient is still breathing, but they're just kind of gasping and taking sporadic respirations. He's coming up into a pretty serious point if somebody doesn't do something about it. Rescue breathing. Manually providing ventilations for your patient. Positive pressure ventilations, and they can be with or without supplemental oxygen. This is indicated when a patient is unable to breathe in and out, responsive or unresponsive. All right, what is meant by positive pressure ventilation? Okay, this is something that confuses people, and it's just a strange concept. All right, so when we take a normal breath in, we know the air flows into our nose and mouth because we create a negative pressure in our respiratory system by contracting the diaphragm. It expands the chest cavity and it causes air to flow into our nose and our mouth. When we are providing positive pressure ventilation, which is what you would use when you're using a bag valve mask, you are creating a positive external pressure and forcing air into the respiratory system. So instead of the air coming in kind of passively through negative pressure, it is being forced into the respiratory system by your bag valve mask. So we're having to overcome the pressure that's internal with a positive external pressure. All right, why is it important to perform rescue breathing for someone in need, even if you don't have supplemental oxygen? All right, so the air we breathe in and out every day, all day, is about 21% oxygen. That is more than enough oxygen to sustain life, obviously. That's all almost every human breathes day in, day out. Some people require supplemental oxygen, but for the most part, we all just breathe normal air in and out. For somebody that needs rescue breathing, if they don't have any major underlying medical issues that would require it, the air that's in the atmosphere is more than enough oxygen to keep them oxygenated until we can figure out why they're unresponsive and not breathing. Opening the airway. All right, you want to ensure the nose, mouth, and the back of the throat are clear of obstructions. Your tongue can be a major obstruction if you're unconscious. If it's not clear, you're going to try to alleviate the obstruction by repositioning the head. All right, the head tilt chin lift maneuver. Patients with no suspected neck or spine injury. If you've got somebody that you think might have a spinal injury, there's another technique of opening somebody's airway that we'll talk about here in just a little while. So the head tilt chin lift lifts the tongue away from the back of the throat and allows air to flow as the patient breathes in and out. All right, the next two figures are going to show the head tilt chin lift. So this is the individual before the maneuver is performed. If you'll kind of look at her, the chin is down a little bit too low. The head is pushing the chin forward towards the throat. And a lot of times this can cause airway obstructions. All right, this is the same individual where the maneuver has already been performed. If you can see it lengthens her neck, pushes the chin away from the chest and neck area, and it'll just pull the tongue from the back of her throat and allow air to move in and out of her body a lot easier. Jaw thrust maneuver. This is the one we're talking about using on an individual that may have a neck or spinal injury. So you're going to position yourself at the patient's head, place the index and middle finger of each hand on each side of the angles of the jaw. Press your thumbs against the cheekbones and lift the jaw forward. You do not tilt or rotate the patient's head at all. Remember, we're protecting the individual from a more severe spinal injury with this. Okay, this is a jaw thrust. The maneuver has already been performed in this particular slide. If you can look at the placement of his hands on the angle of her jaw, he is basically pressing up and it's pushing her lower jaw forward. Lower jaw mandible, if you recall from anatomy and physiology. And this is the view from above of the same maneuver. You can see that her lower jaw is jutted forward. Alright, you respond to a call for a 37-year-old male who has fallen from a ladder. He is unresponsive and does not appear to be breathing. You attempt to open his airway using which method and why? Alright, so this is what we just went over. This is with the where we're trying to decide between using the head tilt chin lift or the jaw thrust. So this gentleman fell off of a ladder. We're going to assume that he possibly has some type of spinal injury, especially since he's unresponsive. So we're going to use the jaw thrust maneuver to avoid manipulating his spine in any significant way. So it's just something to keep in mind. Major trauma is unresponsive and you can't really assess a neurological status of the patient. You always want to go ahead and use the jaw thrust maneuver. It's pretty effective. We'll practice it in class as well. Alright, this is going to conclude part A of chapter 9. Like I said, there's 2 more sections, so we'll pick up with B in the next video. Thanks, guys.
And accuracy is vital. Politely ask the patient to be quiet for a few moments if you are experiencing difficulty with counting. Document the respiratory rate, quality, and any rhythms that you might observe, as well as the time on the pre-hospital care report.